Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another edition of our 5 Slides We're Discussing here at State of Reform. In this time of COVID, it turns out the challenges in health reform don't stop. And so while we are not, any of us, really anxious to get into a room with another few hundred or 1,000 fellow healthcare leaders and health policy leaders, the need to get together in conversation and community is nevertheless still with us, and actually particularly acute. It's particularly acute in Washington State around mental health. And so we're excited to be talking with a number of leaders here in this space, people who are on the front lines and who are thinking both at a granular individual patient level, but also at a system level about the challenges related to mental health in our state as it relates to COVID. Without further ado, I want to jump into our panel today. We're talking about the impacts to mental health and behavioral health in Washington State as a result of COVID. We're joined by Tom Sebastian, the CEO of Compass Health, Dr. Megan Gary, the Assistant Medical Director for Psychiatry at Kaiser Permanente, and Jeffrey Hite, Manager of Provider Partnerships at Beacon Health Options. Thank you very much, all of you, for joining us. Tom, give us a sense first, before we get into our slides and the content we have for today. Tell us a little bit about you, a little about what you do, and what Compass Health is up to these days.
Sure. Thanks, DJ, and hi, everyone. So Compass Health is a community behavioral health provider in the North Sound Health region, serving Snohomish, Skagit, Whatcom Island, and San Juan counties. We have about 30 sites. We serve about 18,000 community members of all ages every year. Our specialty is really serving vulnerable community members who have complex behavioral health needs that include mental health challenges, substance use disorder challenges, as well as complex medical challenges oftentimes. So we provide a full array of services that varies in levels of intensity. We refer to it as our continuum of care. And our goal is to be able to meet anyone with whatever their need is, regardless of their age or where they live, meet that need, and be able to escalate care if their needs increase, and also pull back care as they go through their recovery process.
Yeah, very good. Megan, how about you? Working in psychiatry at Kaiser Permanente. Tell us about the work you've been doing and maybe a little bit about how you've been adapting during this time of COVID.
Yeah, so I'm a psychiatrist at the Kaiser Permanente Everett location, and I've been with Kaiser Permanente for about 8.5 years. Probably a lot of you have heard of Kaiser Permanente. It's a national provider, and we just started in Washington State, since they formerly Group Health, I want to say 7 years ago. But so I've been a mental health provider, psychiatrist, addiction trained during that time, located in Everett, and I've been assistant medical director for the past year. I'm excited to tell the group the robust work that we've been doing with COVID, with our mental health and wellness patients. And so, yeah, that's it.
Yeah, good. Well, I appreciate you making time to be with us. And Jeffrey Hite, Manager of Provider Relationships at Beacon Health Options. Jeffrey, tell us a little bit about Beacon and the role that you play in Washington State's behavioral healthcare system.
Yeah, absolutely. Beacon Health Options operates as the administrative service organization in several regions in Washington, including Pierce County, Southwest Washington, and North Central Washington. One of our primary purposes or roles as the administrative service organization is in the delivery of the crisis system of care. So we're often the boots on the ground interacting in that acute phase or that crisis phase of services. So we're constantly re-examining and exploring, ensuring that we're providing effective good care within the crisis system of care.
Yeah, very good. Let's jump right into our slide deck. I know that you are not epidemiologists, of course, and while you're all healthcare professionals, that does not mean that you think about public health necessarily every day. But this first slide is one that we offer and have brought to the conversation. This is provided by the Governor's Office or Department of Health in regular briefings. It shows the reproductive rate in the state of Washington, differentiated between Eastern Washington and Western Washington. The reproductive rate, in this case, the effective reproductive rate, is the relatively daily or very maybe 7-day average moving number of the number of people a contagious person is likely to infect. This disease started around 3, maybe 2.5, depending on your source, but it has been down in around the 1 level recently in most of the United States. If a reproductive factor is over 1, that means the contagion is spreading. If it's less than 1, that means the infection rate is contracting. So this first question is more to you as professionals and people that think about healthcare rather than behavioral healthcare leaders. I'm just wondering, this sort of slide shows a downward trend and now an upward trend, and knowing the right data is just extraordinarily hard. It's just hard to know because the data seems to flip all the time. So as professionals, as healthcare professionals, how are you navigating this time in terms of leading your teams, taking care of your families? How do we measure when we should start thinking about being more social? How should we measure when we should start thinking about staying closer to home and not go in the office? Tom, how would you offer insights on this question with no clear answer?
Sure, DJ. So, I think that some of it are, paying attention to the basics that we know. So for myself and all my teammates here at Compass Health, we're all self-monitoring every morning, making sure we're taking our temperature, making sure we're monitoring for the symptoms in and of ourselves, making sure we're always masked when we're in a work setting within 6 feet, of course, of any teammates or clients that we're serving. So it's really doing those basic things, the social distancing, the masking, and the self-monitoring. I think in terms of data, I think it's, as you said, DJ, I think it looks like it's going to be, as we're going to move iteratively. We're going to sort of move forward, and then we may have these spikes that occur. But I think that the reality is we just don't know enough about the progression of the virus to really be able to predict. So for a Compass, we've been open the whole time since the inception of the pandemic, and I think it's just being really responsible about our own behavior in respect to each other as teammates and to, of course, those that we serve.
Yeah. Megan, I know we had talked about this question a little bit beforehand, but I actually would like to ask you a different question now I think about it, which is, it feels like we're in something of a honeymoon phase where people are going back outside. People are loosening up, I think, what had been previously pretty restricted social behaviors. Is this maybe too carefree? From a behavioral health perspective, I know people are wanting to get outside. They want to be more social. How do you measure whether it's too soon, or how do you counsel patients or colleagues about how social to be right now?
Well, not being an epidemiologist, I can't give broad recommendations for folks to follow. I can tell you as an organization, what we are doing is we are in coordination with the local Department of Health. We are transitioning to doing more face-to-face visits. When we see patients now, when patients come into the building, as well as when they're not in the building, there's universal masking. So the staff, patients are seen when patients come in, there's a temperature check. And if they're not able to wear a mask, we don full PPE. But, we're committed to following the recommendations of our local Department of Health. And, personally, it's a little discouraging to see the uptick in cases recently in Snohomish. I live in Snohomish. I think the cost on people's mental health with the isolation and the quarantines has been enormous and really underestimated. I'm really glad that we're meeting today to talk about this and to understand strategically going forward what we can do to help people knowing this.
Jeffrey, I know we're going to talk more about crisis services when we get to your slide. Without preempting that discussion, I'm wondering are we seeing, there's a projection that we would see a real spike in different types of crisis moments. People will be self-reporting and relying on crisis services more regularly. Generally speaking, are these as acute as we might have imagined 6 or 3 months ago? Are they delayed? Is the crisis system in general seeing COVID play out?
Well, I think initially we saw some delay, right? I think we saw an actual decrease in service utilization within the crisis system. I think fairly recently we've started to now see an uptick. Both our regional crisis line and then our mobile crisis teams and DCR teams in the communities are starting to see an actual increase in services pretty quickly at this point. I was on a call this morning where we're seeing a 20% increase in mobile crisis response in Southwest Washington over the last 30 days. So I would anticipate that now we're through sort of that initial phase of social isolation. I think we're now starting to get back out more. Providers are starting to open up more and see more individuals. And so I would anticipate that we'll see both an increase in level of services and then also an increase in acuity overall with those we're seeing.
Yeah. Let's get into some of the detail, particularly of the slides that you all have contributed to this conversation. Tom, let's turn to your slide first. Walk us through what you are thinking about and what we should be taking from the slide that you've brought.
So what I want to talk about is the dramatic impact telehealth expansion in response to COVID-19 has had on the behavioral health industry at large, and very much so here at Compass Health. So this graph kind of represents what we've experienced in terms of a dramatic expansion of the provision of telehealth services. So we started a pilot with a technology company partner out of Nevada back in September. And as you can see in the graph, we sort of were working through the use cases and the challenges around connectivity in our 5-county region and sort of working out the bugs, so to speak. And then the pandemic hit in March, and you can see in the graph how that dramatically affected our response in terms of expanding telehealth services as a critical way in which to maintain capacity of service to those that we serve and those that would need our service as the pandemic progressed. So we partnered together with our firm that we work with, and we came up with a new solution within weeks and trained 500 staff on using a new telehealth platform. And you could see that in May, we went from, back in September, less than 500 individuals receiving telehealth services to over almost 5,800 instances of care that we provided in May. The June number is only for about 3 weeks, and so we expect it to be even higher in June. I wanted to note that we're using this in all the different types of services that we provide, and the red portion of the bar is really our general outpatient services, and that's where we've seen the most dramatic expansion. And so we're now able to provide video point-to-point services to all our outpatient clients via our telehealth platform. I did want to talk a little bit about the orange bar. So these are our intensive services to kids and youth through our wraparound teams. We have 8 wraparound teams. Those serve our children and youth with the highest behavioral health needs, including children and youth in foster care. And those teams have made dramatic use of the telehealth platform. We would, without it, have been unable to provide 60 instances of care every day to these kids, particularly kids with special needs that were no longer able to go to school. So what our teams did is they reimagined the way they provide service, and rather than a couple hours of service over a couple days in the week, most of our teams have gone to daily check-ins with the kids, shorter amount of time, providing them activities. But this way we get to lay our eyes on them every day and make sure that everything's going okay for them and for their families.
Wow. Not just a 10-fold, but almost a 12-fold increase over September. That's a significant uptick. Tom, just to clarify, can you talk through how that breaks down by line of business? Are most of these kids? I assume the kids are often Medicaid. Most of your beneficiaries Medicaid? Are all of them Medicaid?
Yeah, the demand since the Affordable Care Act, in a great way, the demand has been so great. We've really doubled our capacity. And to be honest, we have workforce challenges just to meet that Medicaid demand. So we really are focused in on those lowest income earning community members and families. And that's really, a very strong part of our mission since we began back in 1902. So these are mostly Medicaid folks.
And so, Megan, how are you seeing telehealth? I mean, Kaiser's already employed a range of non-traditional services, including telehealth. How has telehealth changed, particularly in your line of business, which is, I believe, mostly commercial and Medicare? Walk us through that.
Yeah, I mean, it's been, there's always a silver lining, right? And I think the biggest thing that excites me, one of the things that excites me so much has been the growth curve with embracing telehealth has just been huge. And I'd say 90%, for a while it was 100%. We were purely phone visits or video visits, mostly video visits. The challenges that we were finding with that was sending out questionnaires ahead of time for patients to complete, your PHQ-9s, your Columbia suicide risk assessments. So the work that we've had to do with our technology department and getting all the providers up to speed to be able to meet the needs of our members doing telehealth, doing virtual medicine has been robust and really challenging. I am really excited about where this is going to lead us as an organization, being able to serve members all the way up to Mount Vernon or Bellingham and be able to meet their needs by telehealth. And that is definitely a silver lining that we've had with COVID and with all the rapid changes that we had to do. I do think there is something missing, right? I didn't go into medical school to only talk to patients on the phone or by video. I mean, there's something really is quite meaningful with that face-to-face encounter. But I'm very excited about what we have learned embracing telemedicine and where this is going to lead us.
Let me ask either you, Megan, or Tom, before I switch to you, Jeffrey. Do either of you have concerns that the supports for telehealth will simply go away? Maybe, the one example is that CMS allows audio only telehealth now versus video as a requirement, which is relevant to the rural communities with limited bandwidth in particular. Is this a special time, or that you fear may end, or do you think that this sort of paradigm is here to stay? Either of you have thoughts?
Sure. Maybe I'll jump in. Sorry, Megan. We've already begun our advocacy effort, TJ, to make sure that the regulatory relief that we got from CMS and other, entities remains in place, because this is really part of the solution long-term in terms of opening up access to care. And it's not just in response, in my opinion, to COVID, it's in response to other challenges we're facing, frankly, as a country. How do we open up access to all our marginalized community members? And I think that technology, it's a tool. It's just one tool. It's not the be all and end all, but I think it's a super important tool and one that we need to keep those regulatory requirements out of our way so that we can provide our community members what they need. Yeah.
Megan, did you want to follow up?
Yeah, certainly, it's, necessity is the mother of all invention, right? And we were fortunate CMS enabled us to be able to do billing for phone visits, billing for phone intakes, which we weren't able to do, and relaxing of the rules so we were able to do these services, as well as also group visits. I am a little worried that that's going to go away. I hope it doesn't. I hope that we can learn from this and then stretch our boundaries, recruiting has always been really easy to do for Seattle, but it's been really challenging to do for sort of like North and South regions. I'm hoping with this more virtual model, it allows us to recruit really stellar doctors so we can serve those South areas of Washington State, those North areas of Washington State, those East areas that services really aren't there. And I really, really hope that we learn from this and CMS learns from this, and I'm sure they will. And then going forward, we're able to strategically serve our members through telehealth means more.
Yeah. I want to move in just a minute to your slide, Jeffrey, but I want to get in a question real quickly for your slide, Tom, from Victoria Evans from our audience. She would like you to speak to the low volume of SUD and adult IOP telehealth visits that you demonstrated on your slide. Any insight as to why that may be the case?
Yeah, we historically have been very strong on the mental health side, and we are building out and expanding on the SUD side. So it's just a artifact of Compass Health, frankly, not any efficacy in being able to provide SUD treatment. I think that for us, we are still, again, waiting for regulatory relief in order to really be able to provide fully integrated co-occurring care to our, so many of our clients that have both mental health and SUD needs, but there's still a lot of licensing barriers there. So that's really mostly an artifact of Compass.
Got it. Jeffrey, let's turn to your slide. Tell us about what you've brought to this conversation.
Absolutely. What we've offered here is an organizing framework for crisis systems of care. So I'd like to review the framework briefly and then talk about possible implications for COVID-19. As we'd all likely agree on the call today, crisis services can vary widely across the state from region to region. So using this framework, we can map crisis systems of care and then begin working to improve access and care in light of COVID-19. What we found in our work in crisis delivery within Washington State is that crisis systems can be incredibly complex. No two seem to be alike. They do not exist naturally, and they must be built and purposefully arranged in order to be efficient and effective as we need them to be. So this visualization includes both the 5 phases of crisis services and 5 key components that need to work in a coordinated fashion to have a successful crisis system of care. So along the top, you've got the 5 phases, right? So prevention, early intervention, acute intervention, crisis treatment, and recovery. And then the 5 key components listed there below include the value of incorporating providers with lived experience into all aspects of crisis system delivery, the need for players as a strong cross-sector collaborative partnership, logistics or the IT infrastructure that's necessary to help facilitate movement of both people who may be in crisis and also the data to make sure we're sharing that data successfully. You've got to have the competencies or the skill of those practitioners providing crisis services to promote resolution and to reduce harm. And then finally, when looking at crisis systems of care, you really need to understand the importance of having all of those necessary parts, not an over-reliance on parts or pieces of the crisis system compared to some of the other events, but we certainly have to have all of those parts and pieces in place. So this offers a great organizing structure for crisis systems of care, and I think we can use this to then reimagine how crisis systems can be effectively updated or improved in light of COVID-19. So some of the things that we're thinking about and would present to the group are, how are racial disparities in case rates with COVID-19 resulting in maybe a disproportionate impact on behavioral health services for communities of color? We need to re-examine this framework through that equity lens and be thoughtful about targeting interventions through that lens. We need to consider where our crisis system continues to support systemic racism or assumptions, and then reinforce our efforts in those early phases of prevention and early intervention so that we're not overwhelming our medical system or our emergency departments in those acute treatment phases. Finally, the one other thing I would direct everyone's attention to is, historically in Washington State, our behavioral health crisis systems have been very heavily reliant on utilization of 911 and law enforcement and emergency rooms in the provision of crisis systems of care. So we really need to use this as an opportunity to consider how we can shift that thinking across the state and have people trained in crisis response responding to people in need versus law enforcement.
Yeah, good stuff. Thank you, Jeffrey. I want to pose this question to you, Jeffrey, from Manjit Sekon. I'm sorry, Manjit, if I know I've butchered your name, but he asked this question of all of you, but I want to direct it to you, Jeffrey. He says, what are you seeing as an effect of COVID-19 on patients who already have mental health distress or who may have already been in contact with the crisis system versus perhaps new patients that are coming in as a result of not necessarily pre-existing conditions, but as a result of the stress here and just living in 2020? How is this experience in the crisis system differentiating, existing known folks in crisis versus new?
Well, I think what we're definitely seeing is the impact of COVID-19, right? We're seeing the impact of this pandemic on, increased social isolation through social distancing, less access to care, is as many great strides as we're making in telehealth, I think people still feel more isolated and feel like there might be less access. So I think what we're seeing in the crisis system is when people do reach out and do connect in crisis, they're often more acute or experiencing a broader range of stressors and vulnerabilities related to COVID-19. Things like loss of employment, loss of insurance or resources they may have had in the past, less ability to connect to family members, less access to, sustainability like housing, transportation, and food. And so I think our crisis system needs to expand to meet that need and offer a broader range of services rather than just that basic crisis assessment.
Tom, let me ask you something that's totally off script, and you've been around us at State Reform for a while, so this sort of happens from time to time. Jeffrey spoke to the inherent elements of race involved in the acuity levels, both with COVID and otherwise. Social determinants of health have been a topic for a long time. In this COVID experience, I heard somebody say recently something that I thought was very smart and which should have dawned on me before, which is that race has no bearing on health outcomes. Racism has a lot of bearing on health outcomes. That it's not just somebody's race, it's the way that we treat people. And so how are you thinking about racism in terms of healthcare in the middle of this COVID experience, in the middle of the upheaval in our country as a result of murders of African Americans by the hands of police? How are you thinking about building a culture that can better address race as well as the social determinants of health? You want to share your thoughts there?
Yeah, sure. We have over different, I've been here for 30 years. And so we've had times at which we've really done a very intentional examination of our own organization and the way we provide services, the way we treat each other as team members in terms of diversity, equity, and inclusion. But most importantly, are we welcoming to all members of our community, whether that's people of color or people of different sexual orientations or marginalized for other reasons. And so we're really going through a very intentional process again right now. I know a lot of organizations are. And I think that it's another time where we really need to take a hard look at ourselves. We need to bring in external people that bring new, fresh eyes into our organization and really help us evaluate where we're at in terms of making sure we're accessible and available and welcoming to everyone, and particularly to our community members that are people of color. So we also then need to continue to challenge ourselves in terms of making sure we're competent in the care that we provide and sensitive in the care that we provide. So now is one of those points for us at Compass, again, as I know it is for many organizations, where we're really going to do a deep dive and make sure that we make the changes we need to make in order to do a better job.
Yeah. Megan, I want to weave together some of these threads and pull in a question from Dan Ferguson. As we are thinking about continuing to serve our communities in this time of COVID with telehealth, with an amplification of the health outcomes, connecting back to social determinants, things like race. Dan Ferguson asks about how to share the workload with workforce that maybe are not licensed as a way, licensed in the same way that we always have licensed caregivers. But how do we meet the demand by thinking differently about workforce to meet these needs of cultural competency and these new needs of technology?
It's a great question. I think Kaiser Permanente's response to racial injustice recently and ongoing has been one of the highlights of working here, and one of the things I'm most proud of. As far as really expanding our workforce to better meet our members and the diversity of our members, that is definitely something Kaiser Permanente is very committed to doing and making our workforce more representative of the members that we serve. Being creative with that's a really excellent question. I think one we should definitely explore, especially when we're trying to meet the needs of our patients in a more broad way. It's an excellent question.
Yeah, there's no clear, no easy answer on that one by far. I want to move to this next slide, which is yours, Megan, brought to us. It's a complicated slide in part. There's a lot going on. Walk us through what you have here.
Well, the highlights of this slide, we got this slide, Kaiser Permanente, our mental health and wellness team. It was actually sent to us, the whole article from the Department of Health and their April publication from Washington State was really sobering, and it led to some work that was pretty incredible to do. And the highlight is really, and this is actually confirmed by what I saw as a clinician at the onset of the outbreak, is tremendous amount of anxiety from our patients. A lot of fear, a lot of worried about employment or financial status and loss of health insurance. And I think what we're seeing now is definitely a greater degree of depression, some grief, some loss. And then I think very interesting, this slide also forecast what we're really, really worried about, and that is an uptick of suicide attempts or suicide completions. And we're looking at like September, October for that. So because of this led to 2 outreach efforts that our mental health and wellness team with Kaiser Permanente did. And the first thing we did is we decided to outreach our most vulnerable members, and those were our Medicare patients 65 and over. And we know that they're quarantined, and we wanted to find out what kind of support do they have. And so what we did essentially is we sent out 1,700 letters and handwritten cards across all 8 of our mental health and wellness clinics, with collaboration with our primary care-based mental health social workers. And the letters were really an extension of non-obliging support, and basically saying, we're here from you, we're here from you, we're here for you, and we care. And it also listed a great degree of support systems that they could reach out to. The second outreach that we did that was really, really incredible, and it was really born out of the work of Dr. Greg Simon, who's a Kaiser Permanente psychiatrist, very famous with his work with suicide prevention in conjunction with our research institute. And what he's able to do is he's able to do a statistical modeling that basically comes up with a list of patients that are at risk of a suicide attempt or completion of at least 3% in the upcoming 90 days. So we had this information, and what has been happening pre-COVID is when patients actually presented to clinics for their appointments, is that a Columbia suicide risk assessment was done at the time of their presentation. And this has been going on for a while. Then we found out with COVID that patients weren't coming in. So what we decided to do was outreach these members. And they generated a new list, an updated list of approximately 800 patients that were at increased risk of an attempt or completion of suicide, at least 3% in the upcoming 90 days. And what we found on this list that really, really kept me up at night was it was a very teen heavy. There were a lot of teenagers on this list. And what we did is we called them across all mental health and wellness clinics, including our mental health social workers and primary carers. We called each of these patients, and we did a suicide risk assessment, getting a Columbia suicide risk score, and made interventions as needed. So this would be an intervention that maybe generated a follow-up visit with their provider, either virtual or face-to-face, or led to an intervention and maybe doing a crisis plan, or maybe a safety assessment, maybe a welfare check. And so it was really good work, and we completed it. We were able to outreach all those members. And we are committed to doing this on a periodic basis, depending on where COVID takes us. So that was really born out of this slide, and it was pretty exciting work that we did with really good feedback from our members.
Let me ask you a follow-up on that, Megan. This question is from Cricket Farr, who wants to ask about getting into the homes and how do you manage technology training when everyone's sequestered. In many cases, mental health degradation happens because they're sequestered, but also because of what's happening in the homes. People are trapped with things that give them stress and problems. How did you sort of navigate the technology? Was it as easy as just using phones?
No, not at all. And I mean, the ideal state is to do video, but sometimes people wouldn't have the capacity for video, or sometimes the technology would fail and you'd have to do phone. I mean, I did a phone intake for an urgent patient in Bremerton that I needed to contact their local 911 to do a welfare check. I mean, it's very challenging. And the theme is you absolutely have to think outside of the box. And you have to stay away from those traditional guardrails that sort of keep us in this particular form of treatment. And you have to think outside of that, especially when you're assuming virtual technologies. I think, the other thing is the video visits give you an opportunity to kind of see people's homes, and how is their self-care and how's their living arrangement? Like, is my patient still in their pajamas and it's at noon? You know what I mean? I mean, there's so much you can sort of assess about someone's level of functioning in their home by virtual care.
Yeah, good stuff. Tom and Jeffrey, Ryan Blackwell has a question about the recent integration of behavioral health and Medicaid, the integrated purchasing or integrated financing and managed care of Medicaid, and the ultimately increased clinical financing that the system has hopes for. Is that behavioral health integration process helping us manage our way through COVID and the BH impacts, or is it providing another sort of layer of maybe administrative complexity and burden? Tom, let me ask you to start first, and then Jeffrey, I'm interested in your thoughts.
Yeah, so here we are only 11 months into that integration process, and I always like to say, it's one thing to integrate the money and the contracting; it's another thing to integrate care. I'm really excited, and we're really excited here at Compass that this provides us a completely different platform from which to really envision a new future of whole person health in a way we never would have been able to imagine in the past. Right now, in the immediate term, it does give us much greater visibility on who from our perspective, on who the medical providers of those we're serving with behavioral health services at Compass. So even that small step is a really big one because that just gives us visibility that we didn't have before and allows us to interact and coordinate care even in these early days in ways we never were able to in the past. And I'll just let Jeffrey, comment. But the last thing I would say is also the plans themselves are a resource to us in terms of having a full picture of who all the systems of care that are involved in with their members might be. And so they're a really great resource to us in a way that didn't exist prior to the integration.
Jeffrey, do you want to follow up?
Yeah, I would agree wholeheartedly with what Tom has said. I mean, I think, operating in a number of regions who went through integration a number of years ago, there are logistical complexities that must be tackled. But I think the managed care organizations have been very ready to take on those challenges. I think we've been very, very successful in adding a layer of coordination between services so that we can get that holistic picture, especially within crisis services. So I think we've seen great success. I think we still have a ways to go, but I'm confident that we're on the right track and working towards success.
Yeah, good. I want to move us to this fifth slide. This is one that we bring to the conversation, but it actually comes from the same document that Megan, you had highlighted from the Department of Health. The Department of Health built a document in April that they've updated every month since that highlights what they believe are the looming impacts to our mental health as a society here in Washington State based on just the wave that we've been going through. This doesn't suggest future waves. It nevertheless is a daunting slide. People can see it for themselves, but I think the point here is that these are the good days in terms of our mental health, and that not only does it degrade as a result of the COVID pandemic and our realization that there won't be a quick and easy fix. But as we know here in Washington State, it gets dark in the winter and sometimes cold and chilly, and that's not going to help either. But that it takes a full year, at least according to the Department of Health document, full year till we get to the anniversary of the onset of the disease, really in March 2021, until we start kind of feeling better about ourselves. This is kind of a depressing slide. Let me just open it up to any of you to sort of comment. I know, Megan, you have at least seen this, and we featured this at State of Reform. Any of you have a response to this one?
My immediate response is I don't want the outreach that we've done to only be in that heroic part. I want us to continue to do this outreach in that place of disillusionment, and to keep this energy going, keep the momentum up.
Yeah, I would agree completely. Within the crisis system of care, this is a scary slide to look at, right? These numbers look like increased services, reaching capacity limits for crisis systems of care. I'm inspired by what Megan has shared in terms of their efforts to be proactive. That talks about that prevention, early intervention, those mechanisms. So I think the more we can pull together, the more our outpatient system of care can provide support in early phases of crisis, the more we'll be ready to manage this as we do go through it over the next year. So some of those efforts, I think we need to continue those, much like what she's talked about.
In this memo, it says as well that 30 to 60% of Washingtonians will experience some form of acute depression, and everybody who gets a diagnosis or has a diagnosis, whether it's actually a formal diagnosis or just the undiagnosed symptoms of the disease or of the difficulty, that about half of those will fall into some sort of substance use disorder, whether that's alcohol or other substances. Tom, how are you thinking organizationally about this? What at least the Department of Health says is a looming wave of substance use disorders coming. I mean, if we're talking 60% of the population, that is across all demographics, that is across all incomes, all lines of business. How are you thinking about preparing for that as an organizational leader?
Yeah, so we had a plan, DJ. We had a plan, and it was to really, in a thoughtful, deliberate way, expand our capacity at Compass to meet the needs of the substance use disorder challenges that community members face. So now the plan's out the window, and now we're really just moving as fast as we can to figure out what are how do we overcome these barriers rather than saying, let's wait for the barriers to go away. We've got to figure out how to overcome those barriers now and make sure that we are playing our part in meeting those needs. I'll say there's another wave that we're expecting, and that's a wave of new Medicaid enrollees. As I'm sure you're aware that, as unemployment benefits, at some point begin to expire and the economy's not recovering, there's going to be also a surge there, which I think, while it's daunting to think about, is a really good thing, because in many ways, Medicaid is as good a coverage as any other in terms of being able to holistically look at the needs of individuals and then really come up with solid care plans that are very comprehensive and really take the whole person into consideration. So for us, it's just moving as fast as we can to build out the capacity, support our partners in the community that are already doing that work. And I think we're all going to have to work together.
Jeffrey, how about you on the crisis side? How do you think about trying to meet this potential explosion in demand?
My immediate reaction is concern that the crisis system could be overwhelmed, right? And so I think, bridging again off of what Tom just mentioned, it's going to take everyone. There's going to need to be a coordinated effort across the system of care. We can't just rely on the crisis system. We can't rely on the concept of adding beds to meet needs. I think we have to look at this holistically and intervene as early and as quickly as possible to get out there and prevent that acute level of crisis. So the more we can do in the prevention, early intervention, the more success we will have in meeting this increased need.
Yeah. Megan, let me switch gears and ask sort of a different question. There's a lot to negatively impact our mental health today, from the economy to our politics to the public health crisis. What gives you hope out of this time? What are you seeing in your workspace related to behavioral health or the healthcare system in general? What gives you hope that you sort of hold on to in these metaphorically dark days?
Yeah, I think for me personally, definitely my family, the faith-based community that I'm a member of. Professionally, what really gives me hope is my colleagues. The fact that despite really busy schedules, they still called all these patients. Gives me hope. The creative thought that our service line is doing in trying to take care of vulnerable members. I think Kaiser's response to racial injustice has been really tremendously inspiring. I think those are the things. I think seeing how communities rally together. And I think my patients, their resiliency, and despite enormous odds. And I'd say those are the biggest things.
Yeah, good. Tom, what gives you hope right now?
Well, I just have a really strong and unwavering sense of faith that we're going to prevail through this time here locally, here in Washington State, across the country, but also that we're going to be successful by also facing the brutal and harsh realities that we're facing and facing them head on. And I think that, in my opinion, we're very fortunate to live in the state of Washington, because I think that's what we've been doing together, from the state leadership down to the grassroots community providers, is that we're facing those harsh realities head on, not pretending it's not happening, but dealing with it head on. And again, with a sense of faith that we're going to see our way through it, do what needs to be done, and we're going to do everything we can at Compass to be a part of that solution.
Yeah, good. Jeffrey, how about you? What gives you hope?
Yeah, I think just seeing how Washington across the state and regionally has pulled together. I think I am so inspired by how quickly we've adapted to the utilization of telehealth. That's something we never would have imagined years ago. And here it is at our doorstep. We need to continue to seize on those opportunities and take advantage of this time to improve our service delivery system. And that's a great example of a quick success we've been able to grab onto in meeting this need. So I hope we continue to push forward with ideas like that that help us continue to weather the storm and get through it.
I want to ask this last question that sort of builds on what we have been asked, or what you have been asked by Manjit again. And he asked specifically about whether there are advocacy efforts related to connecting technology as a public health necessity, framing the deployment of telehealth as a key piece framing the deployment of technology as a key piece of public health. But I want to ask sort of a little more broadly, as we near the end of this, what advocacy efforts are you seeing related to how we respond to this public health pandemic and crisis? And what advocacy efforts should we expect from your peers and cohorts who are trying to challenge this or trying to help us respond to this challenge? What will we be seeing as the policy and advocacy community moves forward? Megan, you want to take a crack at that first?
I'll try to. If I understand, I would see, coming from Kaiser Permanente, I would expect we would continue to do whatever it takes to support our vulnerable members. Certainly, the racial injustice recently has led to a double assault on how patients were already responding to COVID, and then to have this on top of it. I would expect continued advocacy for these members, not just for our members, but also for our staff.
Yeah, staff self-care is something that Cricket Farr had commented on in our thread about the importance of self-care, particularly for staff. Jeffrey, how about you? Where do you see the advocacy conversation leading?
Well, I think we need to continue pushing forward in improving our crisis system of care, right? That's kind of one of our major focuses. So how is our system created in a way that is fully inclusive, allows access for all communities of color, and then improves in a way that streamlines treatment so that we're not going from station to station to station, but rather getting to resolution as quickly as possible. And what does that really look like? Do we need to be in the EDs? Do we need law enforcement intervening first? How do we start to question some of those dynamics and really look to providing true resolution of crisis as quickly as possible to those in need?
Tom, what do you think about the future of advocacy in terms of continued support for the response to this pandemic?
Yeah, a couple of things. One is the telehealth, keeping those regulations out of our way and acknowledging that it is a legitimate service and needs to stay that way long into the future. Secondly, I would say we need to, we still have regulatory barriers that silo us, the mental health system, the addiction treatment system, the SUD treatment system, and the medical system. And we should just speed up the breaking down of those silos as fast as we can, because I think it's going to be critical that we clear the way for integration of care, because I think that's going to be critical in responding to our community members relative to COVID-19 as well. And the third thing I'd add is just continue the advocacy around the development of affordable low-income housing. It's going to be a critical resource in order to create safe, affordable places for folks to live, especially individuals who are homeless.
Great stuff. Tom Sebastian, CEO of Compass Health, Dr. Megan Gary, the Assistant Medical Director for Psychiatry at Kaiser Permanente, and Jeffrey Hite, Manager of Provider Partnerships at Beacon Health Options. Thank you for being part of this conversation. And for the folks who have joined us during this noon hour Pacific time, I appreciate your participation. Recall that we'll send you an update, or rather an email with with a link to this video so you can forward it to your friends. And I'd love to get your feedback on the survey that you'll get from us as well. Until then, we'll be doing a number of these conversations throughout the month, and I'd love to have your engagement. You can always find those at our site, stateofreform.com. Thanks, everyone.
Thank you.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.